Michelle, you want to hit record and then we'll get started? All right, we are ready. Jack, kick us off, please.
All right. Well, thank you all so much for being here. I'm trying to remember when we last met. I guess we had a virtual meeting in January, but it wasn't a very long one. And this one might not be as long as well. So welcome to our March meeting. I hope everyone is staying safe and healthy and you're getting vaccinated. I know there are some people on this call that are 65 and above. I, for one, am one of those. So for those of you that are vaccinated, great. For those of you that are not, I hope you get it soon. And we are wishing you well, peace and health. So today, we want to do some new introductions. We have 3 people that have joined our committee, which is awesome. And Sarah, what do we want to do? Do we want to ask them to introduce themselves and say a little bit about them? Do we want to do introductions all around so they know who we are? What do you think?
I think we want to do introductions all around.
All right. Well, why don't we start with, I'm just trying to pull up my other piece here. Can we put the roster up there now or not? Or I can't, or maybe we can go so I can see everybody. I guess I could do that. Go to my gallery, right? Hello.
We can put the roster up as well. Michelle, can you switch to the roster, please?
Yeah, why don't we do that? And then we can just make sure everybody sees each other. I've got it. Oh, this is fine. Okay, this is great. All right, well, let's start with introductions. I'll start. My name is Jack Friedman, and I've been serving as the co-chair along with Kevin, who's awesome. And I have a history of doing some work at Providence for many years, and have been serving on this committee for about the last year and a half. So welcome. Scott, I believe you're new, so why don't you introduce yourself and welcome to our committee, sir.
Good morning, Jack. Thank you. Good morning, committee mates. My name is Scott Schellenberger. I am the CFO at the Corvallis Clinic. I'm probably a newbie into Oregon. I've been here almost 2 years. I have been in the healthcare space since about 1995. If you've been in the space, I'm a FICOR boy. That legend doesn't seem to go away. I started working in healthcare in 1995. I've been in several multi-specialty clinics, management services organization, most of that time as a CFO, done a couple administrator and COO positions. Spent some time trying to research and understand where the committee's at, and I'm still going to have some connectivity questions as we go along, but looking forward to working with you and being part of the committee.
Well, welcome, Scott. We need loud voices from independent multi-specialty group practice, so it's good to have you here. Thank you. Okay, let's see. Well, let me see here. Kevin, let's go. Kevin, please. I'm going to ask Kevin.
Great. Good morning, everybody. Kevin E. Winchina. I'm a family physician here in Corvallis. I am co-chair of the group, and administratively, I hold a title of Chief Medical Officer of Samaritan Health Plans and Intercommunity Network, CCO. And I am in my 2nd year of being president of the Oregon Medical Association. It's a 1-year term that turned into a 2-year term because of all the happenings of COVID. Happy to be here with you this morning, and looking forward to a great meeting.
Thank you, Kevin. And is Pat Allen with us today? Pat's probably pretty busy, but
I know Pat was going to be in and out this morning, so I'm not sure if he's on right now.
Okay, well, we're wishing him well in these tough times. Craig Anderson, our favorite actuary, maybe our only actuary on the committee. Oh no, that's not true.
No, I think it's not true. Bill's on here too.
Bill's on here too.
Good morning, everyone. That's right. Good morning. My name is Craig Anderson. I'm Senior Vice President and Chief Actuary at Rhode Health, and I've been with the committee since its inception. And welcome to the new members.
Thank you, Craig. Catherine Correa.
Good morning. Thanks a lot, Jack. Thanks everyone for being here. I serve as the President and CEO of Legacy Health. And I was on the committee last year, and I'm moving forward with this year. Can't wait to see what we do.
All right. Thank you, Catherine. Angela Dowling, please. Is Angela with us this morning? Okay, well, we will hear from Angela when we can. Angela, for those of you who don't know, is the President and Chief Revenue Officer for Regions Blue Cross Blue Shield of Oregon. Our other actuary, who has a great personality, Bill Eli. Could you introduce yourself?
It's been a while since I've been introduced as a great personality. So,
For an actuary.
Yeah, there you go. As Jack said, I'm the second favorite actuary, Vice President of Actuarial Service, lead actuary for a few of the Kaiser regions. Most relevant to this committee is the Northwest region for Kaiser.
Great, thank you,
and
Bill.
Looking forward to another year of this.
Yeah. Jessica Gomez, please. Jessica with us this morning? Okay, well, we will be hearing from her sometime, I suspect. And a new person, Meredith Guarino, if I got that right?
Mary Beth Guarino, yep.
Hi, Mary Beth. Hi.
Good morning. My name is Mary Beth. I'm the healthcare advocate with the Oregon State Public Interest Research Group. I think I actually have Scott beat in being new to Oregon. I started back in August as an organizer and then took over the healthcare advocate role in December. So I am excited to be here and do what I can to help.
Great. Mary Beth, welcome to our group. Thank you for serving. Felisa, are you here? Felisa Higgins from SEIU? Maybe not yet. Okay, we will hear from Felisa. Brian Kelly, we saw you. Brian, introduce yourself.
Yeah, Brian Kelly with Women's Healthcare Associates, been the CEO here since 1999.
Very good. Good to have you. Thank you for serving. John McConnell, I saw. John?
Yeah, hi. John McConnell. I'm a health economist at the Center for Health Systems Effectiveness at OHSU. I think I used it within 12 months, but if there's strong demand, I will retell my actuary economist joke at a later point in time.
Is it a long joke, John?
No, it's very short.
All right, do it now, please.
What's the difference between an actuary and an economist?
Anybody want to try that? Does the actuary actually wear shoes?
That's not my punchline.
Okay. Please tell
us. My punchline is an actuary knows they're boring.
Okay. All right. Well said as an economist, John. Thank you for that. Okay. Speaking of economists, is Mark McMullen on the phone? Our state economist. Mark, you there? No, not here yet. Okay. Well, William Olson is a former finance guy, kind of like an economist. William, are you on the phone?
Yeah. Hey, Jack.
Hi.
Yeah. Good morning, Jack. I'm here with you. I was just going to say, you've got me down as the chief financial officer, and they don't let me play with money anymore. So I'm the chief operating officer at Providence. Correct. So glad to be with the group here for the next year.
That's great. We will make that change. Well, welcome. Always great to see you, William. Jordan is here. Jordan Pape. Jordan, I thought I saw you.
I think Jordan had a conflict this morning.
Okay, Jordan's out this morning. And Ken, we saw Ken Preventure, please.
Hi, folks. I'm Ken Preventure. I'm president and CEO of Pacific Source and a continuing committee member.
Good to have you, Ken. Shannon Saldivar.
Good morning. I'm Shannon Saldivar. I'm a small business owner and insurance agent in the Gorge, and I also serve on the Oregon Health Insurance Marketplace Advisory Committee.
Great. Thank you very much for being here, Shannon. We heard from Scott. Is Andrew on from the insurance division? Andrew Stolfi?
Hi, good.
Yeah.
Hi, yes. Good morning, everybody. Andrew Stolfi here. In addition to being a big fan of actuaries, I am the director of Oregon's Department of Consumer and Business Services and also the state insurance commissioner. And I've been with this group since its beginning.
Wonderful. Thank you, Andrew. Good to have you. And finally, is Jen with us? Jen Wheelander?
Yes, I am. Good morning, everyone. I'm the Chief Financial Officer for St. Charles over in Central Oregon, and I've been a member of the committee since this work started. Nice to see everyone.
Great. All right. Well, thank you. I think we've covered anybody. Did I not? Oh, what about, we haven't introduced Michael and Megan. I know they're on. Michael and Megan, do you want to introduce yourselves, please?
Sure. I'm Michael Baylett, and Megan and I have been providing consulting support to the implementation committee since before it was the implementation committee.
That's right. You helped us get to implementation. Thank you, Michael. And Megan, are you there?
Yes, I am. Hi, everyone. I'm Megan Burns, and I've been working with Michael, and we're also providing support to finalize the implementation of the cost growth target. So thanks for letting us be with you.
Great. And we'd also like to hear from Jeremy, please. Would you introduce yourself, and Sarah, of course.
Good morning, everybody. Jeremy Vandy, I'm the Director of the Health Policy and Analytics Division within OHA, which is responsible for launching and running this program. And great to see you all.
Okay. And Sarah, we haven't heard from you. We've just seen you.
Good morning, Sarah Bartleman. I am the Cost Growth Target Program Policy Lead with the Office of Health Policy at OHA.
Okay. And Michelle, I don't know if you're on, but if you are, say a word. No? Is Michelle just kind of behind the curtain making everything happen? Michelle, you're awesome wherever you are. So thank you very much. All right.
Hey, Jack.
Yeah.
There was an announcement in one of the mailings I get about some work that Baylett is doing with 5 states through the Millbank Fund, and I wonder if we could get an update on that either at the end or at the beginning of this session.
That would be great. Yes. Can we, Sarah, can we make a note of that? I think it would be great to get an update from Michael and Megan on that work. I mean, we wouldn't be here without you guys, and we're in your gratitude for all the work you've done to get us this far. Thank you.
Yeah, we can give a quick update when we get to implementation updates. I made a note of it anyway. That's great.
Okay. All right. Well, so for all the new committee members, we're happy to have you. We have a collegial group. Please be honest and forthright and transparent, and don't be shy about telling us what you think about the ideas we're going to be crafting over the next year, because we need everybody's help in this effort. Controlling per capita health spending at 3.4% per year is not for the weak of heart. Okay, so with that, we have January minutes that need to be approved. Has everybody had a chance to review those? Okay, any concerns or questions? And do we need we don't need a motion to approve these, Sarah, or would you like one? No, okay, we're just gonna make note that we reviewed them. There's no opposition, so we'll carry on. Do we want to do a quick review of the agenda and then we'll get started? I'd like to go over it with everybody. By the way, I am leaving early to go to a doctor's appointment, which I haven't seen a doctor in 3 years, so it's about time. And so Kevin will be taking over midway. So thank you for that, Kevin. Do we have the agenda to just pull up so people can just take a quick look?
Yep, it's on the next slide.
Okay, all right. So you can see we've got welcome and introductions. We're going to get implementation updates on our committees. That's coming shortly. We're going to talk a little bit about what payers and provider organizations have sort of bellied up to the bar, which ones we need to find. We're going to talk about our transition to this kind of new phase of work as we start to, meet every other month. Taking action. I'm not sure what that means. Oh, that's that. Oh, yeah, that will be the bulk of our work as we talk about the various committees that are charged with implementing this work. We'll take a break at a little before 10 o'clock. We'll come back and talk about how we're going to start monitoring the progress of this work. We'll have a public comment, and we hope to wrap up before 11. All goes well. So with that, I'm going to ask Jeremy to tell us about the work that's underway as we go into our implementation phases. Please.
Great, thanks, Jack. And we'll talk, as you saw in the agenda, we'll talk a little bit later this morning around the plan for this committee for the rest of the year. So kind of hang tight on that, but you have the work plan in your materials. So you can kind of see the general framework of topics. and we'll hit on this again later, but I want to call out specifically. I know we heard a lot of feedback last year and earlier this year around getting to the data use, and expect those will be some pretty heavy topics at our next couple of meetings. We want to give you each meeting a regular update on implementation work that's happening outside of this group specifically. That was one of the key reasons we wanted to keep you all around, was to make sure that even though some of the details are being fleshed out or implemented in other places, that we're keeping you all apprised of that, and you can kind of see the whole thing being built. We launched a technical advisory group on data submission and data specs that first met I believe in February, and we'll continue to meet monthly. This is a group that's been open. We've sort of opened it up to sort of all comers on the payer or provider or interested parties. So we're not limiting it. This is how we've done other technical advisory groups, such as the all payer, all claims technical advisory group, and they're working on finalizing the data submission template and specs, and then what the data validation process will look like, with a particular focus on this initial batch of data, which will be 2018 to 2020. Eventually, their input's going to lead to administrative rules that we'll need to put into place. And I know staff are continue to reach out to folks who will be data submitters who haven't been engaged yet. Sarah, anything you want to add on the tag?
Just that there's also a tag website and distribution list, and if anyone wants to follow along with that, they are welcome to opt in, listen in, or review the meeting summaries.
Okay, thanks. Data use, as I mentioned, that's going to be a topic for this committee. In future meetings, the quality and equity and framework for monitoring, that's an agenda topic for later today. House Bill 2081 is the legislation that implements the accountability recommendations. That bill passed out of House Healthcare a couple weeks ago with strong support, bipartisan support, and no opposition. It's been a little stalled on a House vote, as I think folks know. The House discontinued floor sessions last week after a positive COVID case, so that could be up for a vote on the House floor as early as today. It seems to be moving along. On the value-based payment front, we're really excited to share that we've made some really significant progress on the value-based payment compact, and thanks to everybody on this committee who's been really helping drive that forward. We've been implementing this through a partnership with Oregon Health Leadership Council. We have 37 organizations signed on, including all of the major payers, largest CCOs, hospital association, medical association, several large clinics. We're going to continue to do outreach to the remaining CCOs, to some mid-sized clinics, to in addition to the hospital associations. Several of the larger hospitals and health systems have signed on, and we're continuing to do outreach to folks, and we'll continue to do that throughout the spring. But later this week, we'll be putting out a press release and announcing the progress that we've made. We think we've got about 2/3 of the entire lives of the state signed on, if you look on the payer side, and probably more like 75–80% if you think about the number of payers that would be reasonable to actually get to sign a compact. We're obviously not going to get the federal government to sign it for original Medicare as an example, but if you kind of look at everybody we possibly could get signed on the payer side, have made really, really significant progress. So we're really excited about that. And we'll continue to invite folks to sign on to the compact after we make the announcement this week, and then are beginning to plan for really the kickoff of the implementation work, which will be a jointly hosted work group between OHA and OHLC. Will include a variety of payers and providers. We're out seeking folks who are interested in joining that work group, and the idea is to do a launch this summer. We decided, given how quickly things have ramped up on the vaccine front, decided to kind of wait till we're hopefully over the hump over the next couple of months, and do a formal launch and some type of event to launch the VBP work at some point this summer. I think that's everything on implementation updates. Sarah, did I miss anything else?
Nope. Do we want to talk about the TA?
Oh yeah, why don't we go to the next slide, and I can do the data submission timeline real quick, and then I'll give an update on the Milbank-Peterson work. So this is the overall timeline that the TAG is working from for submission for the 18-20 data. I won't go through in detail, but you can see basically this spring working through some of the specs for guidance and temporary rules, a template being finalized by May, working with payers over the summer on the submission, and the submission due by September. So that's the overall timeline for that initial batch of data. On the TA side, we've provided a couple updates before that we've been invited in and had applied and been chosen for the Peterson Melbank program for sustainable healthcare costs. They were looking for 5 states to join that, and these are all states that are in the process of launching statewide cost growth target programs. So excited to share that they have chosen all 5 states. It includes Oregon, Connecticut, Nevada, New Jersey, and Washington. Washington also had legislation that passed last year. They have just stood up their an implementation committee similar to this group. I think they've had 1, maybe 2 meetings, and we're working on regular check-ins with their teams as we've both identified especially on the payer side, a lot of overlap, and are happy to hear that. I think they really want to make sure that as they're building it, wherever it makes sense, to make sure they're aligning with the work that you all have set and the direction you all have set, and try to not pull folks in competing directions. So we're really excited to have this connection to other states. Nevada is a relatively newcomer in the mix of states that have been considering this, and not a state we always work closely with on public policy. So that's exciting. And would welcome Michael and Megan if there's anything they would like to add, and I think I saw Rachel from Millbank Memorial Fund on the participant list. So if anybody would like to add anything else, please feel free.
Just that
I don't think so, Jeremy.
Excited to work with you.
Thanks, Rachel. Michael, anything to add?
I'll just note that Oregon and Connecticut are sort of a generation ahead, or at least a year ahead. So both Oregon and Connecticut had their cost growth targets become effective this January. The other 3 states are aiming for next January. So they're a year behind where we are.
Okay. Great. Any questions on implementation before we move on?
Yeah, Jeremy, this is Jack. I had a quick question, and then we'll open it up for others too. On the value-based work, can you just briefly describe, is there a goal for this group? I mean, are we trying to come up with 2 to 3 different models of true value-based that could be agreed upon and implemented by various payers and providers? Are we trying to get to one? Is it too early to know that yet, or what thoughts do you have there?
Yeah, thanks, Jack. So there was a charter that we developed for the work group that I don't have pulled up right in front of me. So I'll try to summarize it, but I'm probably not going to get it exactly right. It's been a while since I've looked at it. There's been a small kind of steering committee, a mix of a handful of folks from this committee and OHLC representatives that we worked on that charter with, and we decided not to try to tackle at the outset that we were going to come up with a set number of models. I think what the group's really going to look at are implementation barriers, try to have a common place where as implementation's happening, we've got sort of a core VBP table that's trying to pull all this together. There's a bunch of other value-based payments happening in a bunch of different locations, whether it's CCO 2.0 implementation, there's a primary care payment reform collaborative, both the PEB and OEB boards are talking about it. So the idea is to have kind of a central home where we're bringing some of those conversations together. The group would be would identify any sort of barriers or obstacles, especially those that are cross-market, and be a place where they can make recommendations both to OHLC and senior leaders of payers and providers in the state, as well as to the state, to OHA or DCBS on ways we could try to knock down some of those barriers to implementation. They also are going to come up with sort of an evaluation plan of how we evaluate value-based payment and whether it's been successful and the impact on cost, quality, and equity, and then sort of report out regularly on what progress we're making on those targets and recommendations over the next couple of years, and whether the targets that were in the compact and the principles are realistic or not, and whether there's adjustments to be made. So that'll be sort of their core group. We did talk about whether trying to align models was the right body of work, and folks felt like no, not right now, but I expected those maybe be conversations as we get an implementation of,
okay, good. And finally, you feel good about the stakeholder participation there, meaning we've got the right kinds of folks around the table. It's not just big payers and big systems. We got some medical groups, et cetera. Yeah.
Yeah, it'll be a mix of hospitals, clinics, primary care, OHA representatives. So I think we had 15 seats and kind of divvied them up. We're in the process now of recruiting and selecting folks. So don't have names yet, but yeah, the idea is to be a mix of a cross-cut of both providers and payers and the state.
Excellent. Okay, thank you for that. Are there any questions for Jeremy on the status of any of this work? I can't see everybody, Sarah. You probably can, because you're a Zoom aficionado. If you see anybody that needs to be called upon or speak up, no?
Not seeing anybody.
Okay.
Give it a moment.
All righty. I think we're good to go. What is our next? Can we get back to our agenda?
Yeah, I can just take us into the next agenda item, which is the draft kind of proxy of payers and providers that could be included in the cost growth target program. So a little bit of context here and a reminder, and Sarah, keep me honest if I mischaracterize any of this. So the way the recommendations from this committee came was that the data will be submitted by the payers. It will be payers that are really doing the attribution to providers. The committee set thresholds for the size of provider organizations that would be included. Both payers and providers on the payer side who would submit data, both for payers and providers whose total cost of care we would measure out. So sort of on the transparency side, and then as well as which organizations could be held accountable. Those are all patient population sizes. And we won't have a final list until we actually get the data submission from payers, because they're the ones doing the attribution, the ones that have contracts with providers. But we also know there's been a big question of sort of which organizations are we talking about? I think we've all, known that sort of the larger health systems would be in, but as we get to smaller organizations, large mid-sized clinics, independent clinics, or who exactly is in, who are we talking about or not? So we've done some work looking through the all payer claims database and trying to match up number of patients that we can see in the all payer claims database to organizations to get an idea of who do we think could potentially be in terms of transparency and accountability. This will change. It's not going to be perfect. Our hope is to be probably overly expansive. The number of organizations probably goes down. Could be some folks maybe we're missing on here, but the idea here is kind of twofold. One, to give you all a better idea of who we're talking about exactly. And then second, for us to be able to start to do some outreach to these organizations so that they know this is coming. I think we all recognize that. I think all the hospitals in the state know this work is coming. Through the Scott with, through the work with Brian and Scott and their independent group, we've been able to do some outreach there. But we know there's folks that we're missing, and so want to be able to start to do education with folks throughout this year. Again, we won't know exactly who will be in the list until we get the submission from payers, but at least want to be able to kind of put folks on notice and be able to continue to work with them and socialize them. So that was really the context of this. Obviously on the payer side, we actually need to identify who's going to submit data. So that one's a little bit more of a more concrete and immediate need. But on the provider side, we're seeing this really as a tool for us to be able to do some education with those organizations and make sure that they're aware of the program. The list isn't binding. It will flex. And as I mentioned, it was based off of patient volume, off of case mix. Obviously, the data in the all payer claims database has a data lag, and so it's not exactly up to speed data. So all of that will shift a bit, but we're hoping it at least gives us a pretty good idea of which organizations we're in.
Hey, Jeremy, can I just ask a quick question? I'm sorry to interrupt you. Have we gotten any feedback from the bigger national players like United or Cigna or Aetna, maybe Anthem? I don't know how much they have here, but can we assume that the bigger nationals, mostly who have self-insured business here, are going to be willing partners in this work?
I know this for sure is on United's radar screen. I'm fairly confident it's on Aetna and Cigna. And I'm not sure, Sarah, if you have any conversations beyond that, or if maybe Andrew knows on the DCBS side.
Mostly, we've been talking to United and Aetna at this point. Both of them are participating in our technical advisory group for data submission.
Right.
And now that we have this preliminary list of payers and providers, we'll be doing outreach to any of the other national folks who aren't already participating. And I think word of mouth is maybe spreading. Aetna joined before we invited them. So
Oh yeah, good.
Folks are definitely aware that Oregon's working on standing up the program.
Yeah, awesome. Okay, thank you both.
I'm gonna go to the next slide. So happy to answer questions about the list. I'm not gonna go through it, but I think really the conversation we wanted to have with you all is, yeah, we feel like there's a group of folks who are pretty up to speed. Maybe don't know all the details exactly of the cost growth target, but know it's out there, know it's coming, and there's folks that this is probably not on their radar screen at all. And so really wanted to get some input from you all on what we should be thinking about as an agency on how we do really outreach and education this year. So wanted to know if you had any thoughts or input on how we should let provider organizations know about the program. That could be one-on-one meetings, could be webinars. There's also sort of the connection between this and value-based payment, and those are sort of simultaneous conversations we want to be having with some organizations. If you have input on materials or communications that would be helpful, or folks would be, if there's an opportunity to kind of divide and tackle a little bit and see if there's folks who have relationships with some of these organizations that maybe would be good to be able to do some outreach together. So I want to just kind of open it up for conversation, see if folks have feedback before we just start hitting the streets.
Okay, folks, any thoughts from any of our colleagues here about how to spread this good word?
This is Craig. Can I make a comment?
Please.
Yeah, thanks. Jeremy, it's getting the word out, I think, from a provider, and this is coming from a payer, so bear with me, and providers might have their own opinion about this, but it seems like it's pretty clear to the payers what it means and how we will be measured. And I think it may be clear to some providers how they'll be measured, but there may be some out there that they don't really understand how they fit exactly into a measurement. It could be an ancillary provider, for example, or one that doesn't have primary care. So that seems like it'd be helpful to, that seems like a natural question that'll come out when we start getting the word out. I don't know what we've done to prepare for that.
Yeah, thanks, Craig. I think we are definitely going to get into some specifics around certain clinics and exactly what types of services they provide, or which providers are associated with them in what way, and sort of what we're counting as primary care or not. So I don't think we've got all the answers, but wholly expect that those will come up in one-on-one conversations, and are also trying to think through the space where we can, invite some of that conversation before we have all of the specifics exactly nailed down. I think how it's going to relate to certain organizations, we're not going to probably know until we sit down with them and actually get a better sense of their business model.
Yeah. Other comments, thoughts? Maybe from some of our new physician groups, any thoughts about, I wonder, for example, if there are rural markets that might need a little more exposure to this work, maybe in Eastern Oregon. I don't know. Any thoughts on that?
I definitely can reach out and ask about that. And of course, if you're having troubles getting a hold of folks there, be happy to participate, or reach out to them directly, or participate with staff to have that happen.
Great. What about
I also think southern Willamette Valley, not just Eastern Oregon.
Yeah. What about the OMA, Kevin? Is the association prepared to, play a role in this at all?
Absolutely, Jack. OMA has had some learning collaboratives already done on the early work that this group was doing. And now that we are moving forward with this, there have been various larger clinics, subspecialty clinics that are wanting to get involved to help understand where
Right.
we're going so they can best educate their constituents, their own clinicians. I did want to make a comment that whatever we choose or however we choose to communicate this, I think it's really, really important to say that this was performed through a multi-stakeholder initiative looking at the why. The healthcare costs are unsustainable, and we all are a part of that. And I want to make sure that that is part of the message because, again, I do not want physicians being under the impression that payers are doing this to them, or that hospitals are under the impression that payers or physicians are doing this to them. We all own a stake with healthcare costs and healthcare quality outcomes. So really important to not pit any organizations against each other as we're moving through the communication process.
That's actually, that's so well said. That could become a public service announcement. I would video Kevin and have him say exactly what he just did, Jeremy, and put that on OPB or wherever and just show it throughout the state over the next 6 months. Well said.
Well, for those that are interested, Jeremy and I will be at the Oregon Health Forum tomorrow morning, and I might be able to reiterate that exact same message.
That's awesome. Well said. Thank you very much. You are a true leader. Other comments? Well, okay. Jeremy, what else is on your mind here?
No, I think we'll keep bringing this topic back and let folks know our plans as we're doing outreach. There's obviously kind of an opportunity in light of the pandemic and everything being remote to be able to do webinars or other types of things and be able to get to folks a little bit quicker. So as we're piecing together our outreach and education strategy, we'll bring that back to you all so you can see what's happening, what conversations are happening. If you have thoughts or input or know of opportunities to try to reach some folks in this, if there's audiences, if there's meetings already happening where it would be good to plug in, please keep those in mind and let us know.
Very good.
Hey, Jack, this is Scott Schellenberger. Can you hear me by chance?
Yes, thank you, Scott. Please, what's on your mind?
All right. So I'm going to ask a little bit of a novice green question here, but when we're talking about reaching out to groups, I'm not trying to whatever, but I mean, our group became aware of this really October of last year when a large part of the work was done. And so I spent some time trying to study and get up to speed and have made some progress with that. But even as a whole, the context of my organization, the Corvallis Clinic in of itself, isn't really aware of perhaps the scope of this, what it may mean, or those kinds of things. So I guess I'm looking for a little bit of connectivity here. When you say try to reach out, are you trying to set up meetings through the OMA, through the administration of the organizations you're working with to set up webinars? And I guess I'm just trying to wrap my head around how you visualize this working. And this may actually be more of a question for Jeremy or Sarah. That just helps me wrap my brain about what we're kind of connecting dots here.
Yeah, thanks, Scott. I mean, I think to put more simply, I mean, for organizations who this isn't on their radar screen, rather than just sending them the report and asking them to read up on it, I think that, like you've had to do, I think, trying to figure out how do we kind of educate them around the work that's been happening over the last couple of years, why we're having this program, some of the details on how it's going to work. We did a lot of I think kind of basic education early on with through the Oregon Leadership Council, the Hospital Association, through a lot of meetings we could find to tap into, and just sort of said, here's a bill, kind of it's coming, here's how it generally works in Massachusetts. We're obviously much farther along in the details now, but I think it's probably a mix of just some basic grounding as well as be able to answer more specific questions that folks will have, which is how does this work and what does it mean for my organization?
Thank you.
Very good. Thank you, Scott. Other comments or questions before we move on?
And I just say, Scott, Brian, you two in particular are probably good folks for us to loop back with as we're thinking about some of these materials. You probably have a good sense of what questions might come up, and how we start with some basic education.
Yeah, I would think so.
Happy to help.
Okay, let's keep moving. Next topic. I'm just trying to get my, okay, so we have Jeremy transitioning to a new phase of work. Do you want to, I think we want to kind of approve our new charter and kind of just make sure we understand the scope of the work in front of us for 2021, right?
You bet. So happy to just kick us off, and Jack, Kevin, Sarah, Michael, Megan, all jump in here as you've got other comments. So we're really transitioning to a new phase of work. As you all know, we've come up with the initial set of recommendations. There's obviously the bill working its way through the legislature, but we are now in implementation in earnest. And so I've been thinking about what the role of this group is going to be throughout the year, and really appreciate everybody's commitment to stay on for another year. There's, I think, kind of two phases here. There's getting through this next year and this initial phase of implementation, and then there's transitioning this committee to a more permanent committee, which might include a different set of membership. So we want to be kind of both making sure we're making good use of all of your time this year while you're still on the group, as well as beginning to plan for what that replacement committee would look like, which certainly could include a lot of folks on here. We're just sort of assuming that there will be some transition as we get almost 2.5, 3 years into the work. Next slide. So I think the big piece for folks to be aware of is obviously the conversations are kind of spanning out. So in addition to work that we'll be doing within the committee, the policy board has a role in implementation around this, and so some of these pieces of this conversation will be going to the policy board as they're beginning to think about their role in terms of the public hearing and annual report to the legislature and general oversight of the program, as well as beginning to think about what the longer term replacement committee for this group looks like. That will be an ongoing committee of the policy board. So we've got that kind of work we'll be having with the policy board. As we talked about, we'll also have the TAG, value-based payment work group, other sort of tangential bodies of work that are really important that we stay connected to. So we kind of see you all as the connective tissue for bringing those conversations together and keep making sure that we're keeping you all apprised as some of that work happens in different places. In terms of the overall program, there's obviously 5 key buckets here. We'll continue to want to do work on transparency and thinking about what public reports look like, and we'll want to have some conversations with you all about that. We'll need to get into the accountability and what performance improvement plans look like. It's required that we have a template, and so need to work through what exactly that template looks like and the details of the financial penalties. We have the basic structure, but we'll need to go into rulemaking and map that out in a bit more detail. We want to be able to really continue conversations with you all around taking action, coming back to really the idea that measuring cost growth is sort of a point in time, but we want to be doing things the other 364 days of the year to make sure that we're actually successful at bending the cost curve, and want to spend some time this year thinking with you all on as we get data and are bringing data forward to you and others, what's the right level of what should we be doing with that data, and when should it result in sort of a new body of work of taking action. We'll obviously have the whole framework around measuring quality and equity and monitoring the program, and then data use is in particular. Heard a lot of questions. Need to come back to some conversation around what data providers feel like they really need to be successful, and recognize that there's a lot of energy around that conversation overall. We've got the charter in your packet, as well as the work plan throughout the year. I don't know, Sarah, if there's anything you want to add on that, or if we want to stop for some conversation, see if folks have any questions.
I think there were a couple of things that we wanted to add, that the work, just being clear that the work might look a little different, and that as the work spreads out, the implementation committee might find areas where there are where you're taking real specific ownership of a part of this, and holding that big picture, and that a lot of this is really setting the stage. So the work plan in the packet is definitely subject to shift as conversations evolve. This is more of a preliminary roadmap, and we'll see how it starts playing out.
Great, thanks. Why don't we go to the next slide? Why don't I do the overall timeline as a reminder, and then and then we can get stop, see if there's questions around the work plan throughout the year of the charter. So I've tried to we've had a couple different iterations of annual calendars, and this is sort of a revised one, but just kind of want to remind folks that this will be sort of on an annual cycle. And obviously the first couple of years is really getting the program off the ground and beginning to look at some of the base data from 2018 to 2020. But once this is in full implementation, it will really be on an annual cycle. So, so first, we'll be obviously measuring whether or not we met the target or not each year. That will then turn into analysis around what's driving underlying costs and costs of drivers. And some of that will be, we think, regular kind of pretty static ongoing reports that would look the same over a period of time. There's some basic things that we would measure probably pretty consistently from year to year, but there will also be some deep dives into that. And as issues come up, working with this committee and its replacement, it would help us understand where there's some places that we really need to do a deep dive. I think thinking back to 4, 5, 6 years ago with hepatitis C drugs coming out and Sovaldi, that was obviously a hot topic in an area that everybody was diving deeper into, was trying to understand what the impacts. I think that would be an example. Obviously, the pandemic's another example. It might not be a thing that we might be doing some different types of analysis and recognition of the pandemic that we would be doing otherwise. We would be publishing the analysis and data to the committee and online for the public. We think about this committee identifying opportunities for where that data then translates into taking action. How do we actually act on it, both as a state, but in partnership with the health systems? And then there's a big body of work that really needs to happen sort of on the ground. That it's really we're partners with that, but recognize that a lot of the work is going to have to happen with providers on the ground in terms of implementing things that help them keep costs down. So that then we'll kind of rinse and repeat each year. So that's our general cycle. Sarah, anything you want to add on that?
Sorry, we'll come back to this slide and talk more about the taking action piece and what that means and what that looks like for you this year in the next agenda item. So we'll come back to this.
Go to the next slide, Michelle. So I think, Jack, if there's folks have questions about the charter work plan for the year, if they're expecting to see something that's not on the list, like now would be a good time to bring it up.
Yeah, great. Please. Comments, anybody? Does this sound like the right scope and tone? Jeremy, I'll jump in. Can I just confirm with you that the Oregon Health Authority is the regulatory group that will be largely responsible for monitoring this work? This is going to be your charge for making sure we understand how the per capita spend is going, where the opportunities for improvement are when it comes time to taking some performance improvement plans, which is a ways off. I get that. OHA sees this in your bailiwick. Is that fair to say?
Yeah, absolutely. The legislation is very clear that OHA is the one that really has accountability for running the program, but that it's also clear that we will do that in collaboration with DCEFs. That's called out in the bill, and I think Andrew's team and our teams have been working really, really well together. So there's certainly collaboration there, as well as the legislation calls for the policy board to have an oversight role, which I think is really in that space of monitoring statewide costs and the public hearing and annual report that will come as part of the work.
That sounds great. I just wanted to clarify that, make sure that everybody understands that. Are there questions on the charter from anybody? Please. Okay, well, so silence can be golden. And so I'm sensing that there is do we need an approval of this charter or no? We're just gonna make sure that everybody kind of has a chance to weigh in, and we've had that. So I think we can move
Jack,
on.
Catherine's got her hand up.
Oh, good. Catherine, thank you.
Yeah, so Jack, thanks for the question, and was able to read the charter red line version. So thank you for including that in the packet. I don't think there's anything to be, discussed per se in the changes to the charter. But I would just, mention that it haven't had the opportunity to really process it deeply and to talk with folks, at least in my shop, that, will be responsible for working through this. So in the future, it would be helpful to have these a little bit earlier than we've had them. I certainly understand the workload and just kind of the tough timing that we're under. But I think the charter changes reflect what we talked about in the last couple of meetings.
Okay, well, thank you for that. The other option is to give folks on the committee a chance to review it now with your internal teams and make sure you're comfortable with the scope and the language. I don't think we want to do a ton of wordsmithing, but the general tone of it. And I guess if there are concerns, Sarah, Jeremy, we could have that come back at the May meeting. Is that fair to say?
Yeah, absolutely. And recognize everybody is completely swamped right now, and getting shots in arms is people's number one priority. So certainly, I think if folks have feedback after the meeting, send that in, and I think we could just couple this with approval of the minutes at the next meeting and make sure if there's any other feedback or approval that we need, we can do that formally at the next meeting.
Terrific. That's a great process. Thank you. All right.
Jack, would someone comment? This is Brian. Apologize. Just the term data use strategy. I just like to understand how that's defined, and then maybe scope of that. Just my ignorance. I'm happy to take that off.
No, that's a great question. That's a great question, Brian. Jeremy, do you want to respond to that?
Yeah. Let me take a crack, and Sarah, Michael, feel free to jump in. So, I think generally the way we've thought about this program is that, as I mentioned earlier, that measuring cost growth is sort of just a point in time and not really, it's obviously kind of an anchor in how this whole thing's going to work. But really we've seen it as a way that we're bringing a lot of data that the state already has, frankly, as well as some new data together to really help us try to understand what's driving costs and where the opportunities and challenges are in a given year, and that will be work that needs to happen sort of on an ongoing basis before and after the point in time that we measure did we meet the cost growth target or not, and that really needs to also couple with and worth working hand in glove with the health system to be able to say what types of data or information or analysis would be most useful for you all to try to understand where there's opportunities. So we see that as really both sort of some regular kind of static annual reports that we would do an analysis we would do, as well as some kind of ad hoc or other types of kind of varying analysis that we would do. I think an example of this is this last year we did ran Milliman's waste calculator tool through the state all payer claims database in partnership with the Oregon Health Leadership Council for identifying opportunities of low value care. And that wasn't we didn't go out to the health system and say you need to change X, Y, or Z. The idea was really to take data that we had and be able to do some analysis and put that out there for the health system to say, here's some opportunities that might make sense for you all. Where that ended up going was there's a evidence-based committee of the Health Leadership Council that includes a lot of the CMOs from payers and providers, and they picked vitamin D testing as sort of an area they really wanted to lean in for the next year, and kind of gave them some data to say, okay, we kind of know an area where there's some low value care, where maybe there's some low hanging fruit. So those are the types of things that we would want to be doing throughout the year. I don't know if Sarah, Michael, anything you guys want to add?
I think we're using data use strategy as a catch-all term to describe that whole process of what are these analyses, what's the timing of them, and what's the communication. So when we're thinking about bringing the data use strategy conversations back to the committee, it's twofold. It's both looking at our plans for that. We've got a really long wish list of analysis that we would like to do and helping us prioritize. And then it's also reviewing the results of those analyses and thinking about implications for taking action. So this year we'll be doing a bit of both.
Thank you.
Other comments from anybody, please? Okay, well, we're making good time. Jeremy, is there anything else in the charter or this particular section of the agenda that we didn't get to?
I don't think so. Like I said, if folks have questions or feedback, please feel free to send that to us between meetings here.
Great. Okay, well, actually, we're kind of right on target here. So now we have a 15-minute slot before we take a break to really get into how we're going to prioritize this work and in particular, taking the right actions to make sure that we have a great implementation. So I believe Michael and you and Megan and Jeremy are going to lead us through this. Is that fair?
That's fair.
And Sarah, I guess Sarah will always be part of that. Okay, please.
I can kind of tee it up, and then Michael, let you and Megan jump in. Let me go to the next slide. So I think this is a beginning of a conversation we want to have throughout, probably over a period of a couple of meetings. But we have been doing analysis kind of in the background on what do we know is happening with costs and cost drivers, what's been happening with price and utilization in the state. We want to start to bring some of that forward to you all. We presented a lot of this when we kicked off a lot of this work a year and a half ago, but we've been able to get it kind of deeper and deeper. We recognize that every time you bring data forward, that just raises a lot of questions, and it also creates this, this space where people suddenly want to sort of like veer off and take some action in a direction. So we want to start a conversation with you all of, as we're bringing, data analysis forward. Is there a framework for when what we should do with that and when it should translate into actually taking action versus just sort of context before we bring something forward to you and then you say, okay, now we need to like sort of jump left or jump right. And we thought maybe it would be good to be able to start to tease out, is there sort of like a framework for, as data is coming forward, we understand when it should relate to a broader conversation of, does this inform how we should be thinking about future analysis? Does this inform work that we should be doing that should spin out of this? Is it just context that we should be thinking about? We also expect that there's just going to be, and I'm sure you all feel the same way with your own individual analytics shops, there's just always a longer list of things people would like to dive into than we ever have bandwidth to do. And so also thinking about how do we kind of prioritize the things that are sort of the most important. There's two analyses that we've had that are kind of going in the background. One is there's a organization called the Healthcare Cost Institute that puts out information on price and utilization but for every state and kind of what the changes are broken down by big service categories. The problem with HCCI is that they use usually data from some larger national payers, which don't have as big of a presence in Oregon. So they produce Oregon data, and we've shown that to you in the past of sort of what are our trends with price utilization. But it's a relatively small amount of claims they're looking at. We've been able to work with them and take their methodology and run it through our full all payer claims database. And so we can now sort of show you with a much broader set of data what has been happening with price and utilization. We're close to having that report finalized. We'd love to be able to spend some time with you all going through it. But again, recognize that will probably spur a whole bunch of questions about what do we now do with this information. So want to be able to start to talk with you all. Is there a framework of kind of how this group would want to operate as we're bringing different bits of information to you throughout the year? So with that, let me turn it over to Michael.
Okay, thanks, Jeremy. So I want to share with you all a little information from Rhode Island. Rhode Island's a little ahead of Oregon. Their cost growth target became effective in 2019. And so they've been spending most of their time in the committee that looks like the implementation committee, focused on their data use strategy and analysis of their all payer claims database to get insights, and then identification of strategies to advance cost growth target attainment. And what became apparent early on was that their data use strategy was identifying multiple opportunities, and members of their implementation committee-like structure were beginning to bring forth ideas of actions that should be taken to support cost growth target attainment. And their governance body didn't have a means for determining which of the opportunities, which of the strategies were most deserving of pursuit. So they developed a set of criteria against which every potential strategy would be assessed to determine whether or not it warranted prioritization and recommended action by, again, their implementation committee-like body. They started first with pharmacy because they performed analysis of their all payer claims database that showed that increases in spending, almost all due to price, on both retail pharmacy and what they term medical pharmacy. So these are physician administered drugs. That pharmacy price alone accounted for a huge percentage of what they were seeing in annual cost growth for both the commercial population and the Medicaid population. Worse for commercial and Medicaid, but significant for both. And so before deciding whether to recommend action on pharmacy price, they ran the strategies up against these criteria. Now, they've got other strategies that they're considering. They've done some analysis on low value care reduction and whether that's going to be an opportunity. They have not assessed it against the criteria yet. Like Oregon, they're also looking at accelerating value-based payment adoption as a potential area. And so all these ideas and new things that they're looking at, including specialty spending, all of those are going to get run up against their criteria. So why don't we go to the next slide and I'll share what do those criteria look like. This is in simplified terms. Simplified terms, one criterion is that the analysis of data indicates that there's a significant opportunity, and additional information framing that says the significant opportunity is such that action would impact cost growth target attainment. So if the amount of spend or the opportunity is so small that it wouldn't actually make an impact on cost growth target attainment, then it doesn't measure up. Two, that the strategy is actionable at one or more of the following levels: state action, payer action, and provider action. So someone has to be able to do something, or someone's, it doesn't have to be just one. And then third, there needs to be capacity to execute the strategy in a way that's going to be effective. I'll also add, they have as a sub-bullet under one of these, that there needs to be evidence supporting the strategy, or else an overwhelmingly compelling logic model supporting the strategy. So this is generally what they're using as a construct for evaluating every strategy and deciding which ones to advance, because obviously the implementation committee, nor any other state's implementation committee, is probably going to be unable to move 10 big rocks up a hill at the same time. So this is a means for trying to decide which ones are most deserving. Any questions about what Rhode Island's doing?
Oh, very helpful. Other comments?
Catherine.
Catherine, it looks like you want to say something.
Yeah, thanks for that, Michael. The committee and staff have capacity to design and execute. The last bullet there. Any comments or detail around exactly which committee and which staff talking about?
Yeah, so this is their version of the implementation committee. So to the extent that there needs to be staff work to support it, and that's not always the case, but if it requires staff work, then the staff's able to do it. They've already got under their second bullet here that it's actionable by other parties, but to the extent that there needs to be staff work to support it, then that they believe the staff can take it on.
Yeah, so that's kind of interesting if something would be significant and relative to the design and the data use. So yeah, all of those sort of come together there. Thank you.
Mm-hmm. Okay, so I shared this because I think the question that Jeremy put forth in the introduction is, would it be helpful to have something like this as the implementation committee begins to consider strategies in the future?
So Michael, this is Kevin here to help answer that question. I was wondering, did Rhode Island develop an algorithm or a scoring mechanism to help rank which new ideas were moving forward, which ones maybe didn't score high enough to move forward? And would
Yeah,
they be
it's a
willing
good
to
question,
share?
Kevin. And so right now, they're sort of coming forward one at a time. One could make an argument that it might be a worthwhile exercise to try to identify a whole set of potential strategies and review them together. But there's, which I think is probably worth doing. But I'll also say, to the extent that the opportunity identification is going to come through the data use strategy, and the data use strategy is going to be a little bit iterative and isn't going to produce all the analyses at once, there's probably some benefit maybe at the outset to say, hey, let's look at a whole batch of strategies that we've identified and look at them together to prioritize, but also to recognize that over time, there are others that are going to pop up, both because additional analysis has been performed or because circumstances have changed and there are new opportunities that appear that didn't exist the prior year.
Great, thank you. Yeah, I'd definitely be in favor of some type of scoring rubrics to help us along, because the term has been made before, stated before, we can't boil the ocean. So once we start to develop new strategies, how do we see which ones might be most applicable broadly, give the biggest impact, and then move forward with that? So yes, a model to identify new strategies, but then prioritize which ones make sense in moving forward first, because of limited bandwidth from staff and also limited bandwidth from the implementation committee.
Yeah, so that their approach really has been pass fail thus far. You know, does it meet the criteria or not? But I could imagine having a scaled scoring that would lend itself to prioritization, especially if you're looking at multiple strategies at about the same time.
Great, thank you.
You know, Michael, this is Jack. The process you're describing to me is not unlike what I remember health plans generally doing, where the finance leadership is looking at their quarterly per member per month expenses, and the salespeople are trying to get the premiums down so they can sell more insurance. And there's usually an internal process where medical management people and provider contracting people, Bill and Craig and Ken, help me out here, please, come together to look at various opportunities, either on utilization improvement, price per unit of service improvement, et cetera, et cetera. And we should know how to do this. This is kind of the way most health plans try to run their business, I think. I don't know about large provider organizations because they don't typically have total cost of care, although that's changing with risk. So you guys have any comments on this? Craig or Bill or Ken, that would help inform this a bit?
Yeah, Jack, I'll go first. This is Craig. And that's exactly where my mind was going. What we do as a health plan to identify and prioritize what we call cost savings opportunities. But maybe the opportunity here, though, is to think beyond just an individual health plan and be more system-wide. And some of, I think, what we do as a health plan can get contentious potentially with providers around certain services or utilization, prior authorizations. But if we could get past that and be more collaborative, I think that's an opportunity. So I'd be kind of curious, Michael, if you have other examples beyond pharmacy that Rhode Island identified that might help us think about other areas that they've focused on. And the other thing too that comes to mind is, so much of the healthcare cost is beyond just the healthcare itself. It's the social determinants is maybe 80% of cost. So do they look at upstream opportunities as well that might influence outcomes?
Great question.
Yeah, they have not yet. I think, they might. I think the focus right now is on actions for which there's a belief that they could see some benefit in a relatively short term, but they're still relatively early in this. They're further ahead than we are, but they haven't been doing it for that long. They've only run 2 strategies through it so far.
I've got a question.
Okay, please.
Oh, no, go ahead.
Yeah, no, John, please. And then I know Felisa looks like she has her hand up. I'm glad to have
Oh, sorry.
you on the
Let's do
phone.
hands up. I didn't do my hand up. Let's go Felisa first.
Felisa, you want to ask a question? Then we'll go to John.
Sure. Sorry. I'm having construction, so my video is real spotty, but I guess I think the question you're asking us is about I think it's a good idea to have a set of criteria. And so I'm really committed to that. I feel like I have some questions about maybe additional criteria that Rhode Island isn't using. So for example, the ability to make a change. Because I assume that in the health plan analysis and in most organizational analysis, you analyze the length of time to impact to make the change. And so I'm wondering if it seems like they just started it, so maybe that's not part of it yet, but I'm all for criteria, maybe shifting these criteria a little bit.
Yeah, I mean, I certainly think that they can be modified. I don't think that they reached criteria nirvana. I mean, they try to get at that, Felisa, a little bit by saying that it's actionable and that it's going to have a substantive. I'm looking at that. You saw a summarized version on that slide. The actual version says strategy implementation is likely to have a substantive impact of cost growth, target attainment in the near term, or stages future work that will have such an impact. But certainly, what they wrote can be modified.
All right, I know that John had a comment, and I see that both Bill and Ken want to comment. So John, please.
Yeah, just kind of building off of your note that this is a lot of what health plans do. I think one thing that's different here is that it sort of provides a third set of eyes on the negotiation part, and so and I think somebody in Massachusetts described the benchmark as targets, hope, and shame. That the idea that there's somebody else watching, and that it would be not so comfortable to ask for a 15% price increase. So, and that sort of strikes me as maybe, somewhere in between like data review and then sort of a specific algorithmic action that you're taking. And so is that part of the conversation? Is that assumed to be implicit in all of this, or are there ways to kind of surface data or surface some of the kind of what's happening, or to broadcast that will be happening in a way that is formalized in all of this, or what does that look like, Mike?
Yeah, so John, I think you're really talking about how do strategies emerge. And as I've thought about this, there are two different ways. And I'm thinking about them as sort of macro strategies and micro strategies, and those might not be the right terms. But macro strategies are addressing systemic influences on healthcare spending. And I would say that the conversation that we've had about value-based payment is one of those. Payment, writ large, impacts healthcare spending. The data use strategy, though, that's going to do drill downs into what's driving Oregon cost growth from year to year is going to be much finer and more micro in orientation. So in Rhode Island, they focused on pharmacy price and what percentage of total spend growth was attributed to pharmacy price. And now they're drilling into professional spending. And in Connecticut, they're drilling into hospital spending. So those analyses are going to be much more data-driven than looking at the macro factors like payment models. And I think both have merit and both should come to the table, so to speak.
Yeah. Bill and then Ken. Bill, please.
Yeah, sort of to build on what some others have said in terms of that health plan view. I think, yes, it's a similar framework here that we utilize in health plans. And a lot of this type of work is sort of our, daily bread and butter, if you will. I would point out that health plans, though, typically add a piece of looking at drivers relative to expectations as opposed to the actual dollars themselves. So, for instance, in this context where I think it's important is when you start talking about, site of service opportunities or continuum of care, where, hey, I see data and it looks like, and cost increase. And for example, hospital outpatient facility charges were driving that. Well, if we have some sort of program, statewide health plan, more apt health plan, that we're reducing unnecessary admissions and changing site of services for some procedure in the outpatient, you would absolutely expect that to be happening based on the data. So the key is, I think this framework, all needs to be put into this total cost of care framework. And I fully support and understand the need for specific data studies, but there probably just needs to be some input from this community as well as other experts on, sort of picking those key things we want to look at even before the data comes in. So for instance, we've been talking about pharmacy, but somebody had mentioned, I'll use our term, but clinical administrated medications. So I can tell you without looking at the data, year over year, you're going to see a pretty big increase in unit cost on the oncology drugs that are canned. So that's something I would think would want to look at. So I guess the point being, there needs to be a layer beyond the data of just this group and people within OHA suggesting some targets to really look at in addition to the hard data of what we're finding.
That's a great comment. Yep.
Yeah,
Well
let me
said.
add, Jack.
Yeah.
In Rhode Island, they have created I would say, a flexible work group that meets with the people doing the data analysis to review the analysis and to help interpret it, and to identify where there's an opportunity before it goes to an implementation committee. Yeah. And it's a flexible group because the composition varies based on the subject matter, because they want to have subject matter experts relative to whatever the area of inquiry is.
Yeah, that's good. Yep. I'm going to sign off here in just a second, but before I do, I want to hear what my friend Ken Preventure has to say here.
So I guess I have a bit of a different view on this. I feel like we've made a pretty significant commitment to the value-based payment initiative as a strategy that will really require significant bandwidth and effort by the system. I'm a little nervous about having a huge additional process that could look at generating other major initiatives. So I think we should be cautious and not be moving on too many fronts at the same time.
Yeah. Okay. Yeah. Okay. Good. Your point there, no, that's fair. Your point being that if we shift the risk to integrated provider systems, they should have the internal tools to some degree to kind of manage that total cost of care.
Well, I don't think it's that simple, obviously, but I do think that it gets to the total cost of care, and there may be different variables in different places that approach has an opportunity to address.
Okay, very good. Thank you, Ken. All right, folks, I have to leave, so I'm going to turn this over to Kevin, and I wish everybody well, and we'll see you in a couple months.
Thanks, Jack. Hey, Kevin, as you're taking over here, I wanted to just touch, I saw Jessica joined. I want to make sure Mary Beth or any of the other new members, if folks have questions, just want to make sure we call on you specifically.
Absolutely, and maybe we could have those new members just give a quick introduction, because we have brand new members to the committee today. So I'll start with Jessica. Jessica, if you wouldn't mind introducing yourself for the benefit of our new members.
Oh, sorry about that. Just have to unmute. It's great to be here. My name is Jessica Gomez. I'm the founder and CEO of Rhode Valley Microdevices. We make microchips down in Southern Oregon.
Thanks for joining, Jessica.
Thank you.
Is there anybody else on the implementation committee that joined us later and has not had the opportunity to introduce themselves?
Hey, Felisa.
Hello. This is Angela Dowling. I joined late in today's discussion, so I apologize. I'm not new, but I apologize for being late.
We're happy you're with us, Angela. Felisa?
I'm going to try some video. This is Felisa Higgins. I'm a political director at SCA Local 49.
Great. Thank you. All right, and I think then introductions have been recaptured again, so we're ready to move on.
I think Catherine has her hand up.
Catherine, yeah, I see your hand up. Go ahead.
Thanks for calling on me one more time. But Ken made me think of this, and it actually goes back to the first question that I asked Michael, but my thought hadn't been quite formed. When Ken talked about the total cost of care getting us to an outcome, right? And that process really being one of the macro drivers that you talked about, Michael. I'm wondering in this particular section, as we think about the data and how we look at it, if one of the things that we could think about is not so much the criteria of the actual data that we would find, but that you insert a little bit of that thought process around testing it for its viability to make the impact, not in the 3 criteria that's part there, but to, as it goes to implementation, to do small test of change before we sort of sanction larger mandates or big initiatives. Back to Ken's perspective on how big does it have to be? If it's big impact, modest amount, easy design, then it seems like that would be something that we would want to go for. Back to that capacity around everyone at the table, and that sort of minimally viable product approach might be something that helps us actually get some traction and back to the results of actually lowering the total cost of care as a contributor. Just a thought of trying to weave it all together.
That's a good point. Michael, any thoughts about that? And is Rhode Island doing anything related?
Yeah, that makes sense to me too. It seems to me it would be dependent upon what the strategy is. I mean, what they're doing right now on pharmacy is they are supporting 2 bills. One that would penalize manufacturers for drug price increases that are more than 2 percentage points above CPI, and the other to do international reference pricing relative to Canada for drug prices. Those probably wouldn't lend themselves as well to the small test of change, Catherine, that you recommended, but I could imagine other interventions that might.
Any other thoughts or questions from those on the committee that haven't had the opportunity to speak yet? All right. Michael, were you leading us through the next question to ways the committee can handle these types of conversations, or do you feel we've already been talking about that?
Jeremy, what are your thoughts?
Unless folks have some other thoughts, I mean, I think we can maybe pick this back up if we're going to bring a straw proposal back, and maybe a little bit more concrete conversation at that point for folks to kind of wrap their heads around. But I think we're starting to get there. I think folks are starting to see the same thing we've seen internally, which is we can put some data in front of folks, and then they're like, "Let's jump, let's go do something," and we want to make sure that if we decide to do that makes sense in the context of all the other stuff that we're trying to do in terms of, you know, big picture total cost of care, value-based payment, you know, and obviously dollars in healthcare are enormous, and so sometimes things look big, but on the grand scale of how much we spend on healthcare, it's not that big in the grand scheme of things.
Okay, and with everything COVID and vaccine related going on, do you feel bandwidth wise you'll have staff time and the ability to look at bringing a straw model back to our May meeting?
Yeah, I think so for sure, and we can weave in the comments that we heard from folks today.
Great. Okay, so if other task force members have additional comments, please submit that to Jeremy and Sarah, and we will continue to watch that and then bring a straw model back in May. All right. Looking at the agenda, is there anything else we wanted to take care of before we get to, I think the next thing is our break?
We're running a little ahead of schedule, but I
Which
think
is always good in a meeting, yes. All right, so now is our time that we are planning to do a 10-minute break. We're ahead of schedule, as Sarah just stated. So the time is now 9:27. Why don't we take a 10-minute break? We'll plan on reconvening back at 9:37. Welcome back, everybody. The time is 9:37, so we're going to get started with our next section. And we're going to be having a framework for monitoring next. So I'd like to invite Sarah to lead us off with that discussion.
Great, thanks, Kevin. So the framework for monitoring is really a new document, a new discussion, but it really is how we are packaging up and moving forward to implement the committee's recommendations, your recommendations from the quality and equity work stream. So as we've been reviewing the recommendations since January and figuring out what the next steps are for implementing that and where additional content needs to be developed, where additional coordination needs to happen with other committees or other staff and agency work, we're really starting to pull it all together under this framework for monitoring. So there is a full framework for monitoring document in the packet. It is draft. I'll talk more about that in a little bit, but Michael and I are going to walk through some slides to give some context and framing and then tee things up for your discussion.
Thanks, Sarah. Oh, Michelle, perfect. So the January recommendations report identified 3 separate strategies. That one is that there would be reporting on a standard set of quality measures in parallel with reporting on cost growth target performance. There'd be monitoring for unintended consequences resulting from implementation of the cost growth target, and there would be measurement related or based efforts to improve equity. To help give some context, I'm going to share some examples again from other states that are doing cost growth target work, just to give you a basis for comparison. So the first thing I want to do is share what other states are doing on this top green box, reporting on a standard set of quality measures. Michelle, next slide, please. So Massachusetts, Delaware, and Connecticut are 3 cost growth target states. They're all doing different things on reporting on quality measures, but they are all doing so in parallel with their cost growth target reporting. So Massachusetts reports annually from a quality measure set, and they actually have an annual report that's produced on the performance of the healthcare system. It's not specific to quality. And I would say that the quality measures really aren't tied explicitly to their cost growth target, but there is parallel reporting of performance on quality. The other 2 states listed here are a little bit more tightly integrated. In Delaware, they're operating under an executive order, not under statute. And the executive order established cost growth benchmarks. They use benchmarks instead of quality, and quality benchmarks at the same time. So they're viewed as equivalent. And there's reporting to be done at the same time on their cost growth benchmark performance and their quality benchmark performance. The quality benchmarks are mixed. Some of them come from insurers and reflect performance on prioritized healthcare quality measures, really all health plan HEDIS measures, but they also adopted some population health measures that look a lot more like public health measures. And so they've got a mix of quality benchmarks, healthcare and population health. Finally, Connecticut, they are also operating under an executive order, and that executive order also established cost growth benchmarks and quality benchmarks to be implemented, but in staggered fashion. So their cost growth benchmark became effective this January. Their quality benchmarks to be defined will become effective next January. So these are all ways that the other states have tied in an approach to quality and to quality reporting. I'll also share that in Rhode Island, there have been conversations about whether they should expand their focus to quality. They haven't done so yet, but we'll see what happens. So that's reporting on quality measures. The second of the 3 strategies was monitoring for unintended consequences, and there's one example there. So Michelle, if you could turn to the next slide. In Connecticut, there was concern from some patient advocates that their cost growth target could be harmful. And so before their cost growth target even became effective, they developed an unintended adverse consequences monitoring plan. It has 3 different types of measurement foci. It's going to look at whether they're, and all of this is to be done on a pre-post basis. First, whether there's a reduction in utilization of both preventive services and chronic illness services. 2, whether what they defined as marginalized populations are adversely impacted. I would say that this is integrating an equity perspective into assessing adverse consequences. And then 3, they're bringing specific focus to trends in consumer out-of-pocket spending. I will note that Connecticut just did some analysis out of their APCD, and they looked at spending between 2015 and 2018. So I've got 3 percentages from that time period that you'll find of interest. One is consumer wages grew 1.47% per year during that time period. Commercial healthcare spending grew 4.9% per year, and consumer out-of-pocket spending for commercial coverage grew 8% a year. So 1.47, 4.9, and 8. And so clearly the consumer out-of-pocket spending is growing way faster than wages, which is why that's the 3rd part of their plan. I also want to note that that consumer growth and out-of-pocket spending isn't necessarily resulting from a cost growth target or cost growth benchmark. It's really derivative of the problem of high expenditures and changing benefit plan designs from employers and employees. But nonetheless, these are the 3 areas of focus for their monitoring for unintended consequences.
Thanks, Michael. So one thing that I wanted to just be upfront about, because we are making a change in terminology, and you'll see this reflected in the document, the full framework document throughout. The committee, you originally used unintended consequences to describe these adverse effects on members and patients. Again, we had been looking last year at the work in Connecticut that was emerging. We were really interested in having a similar strategy. As we've been talking about this quality and equity work stream with the Oregon Health Policy Board, with staff and the chairs of the Health Equity Committee, there have been some concerns that this language of unintended consequences is too narrow and that it really doesn't affect all of the potential impacts on equity. So there had been some other suggestions for what this could reflect, not all of, or what we could call this body of work, this strategy. Not all of those suggestions reflected your original intent for this strategy. So we have landed on negative impacts of the cost growth target as a bucket, as a catch-all term that will include both some of the original unintended consequences considerations and some of the potential impacts on equity that other stakeholders have raised. So from here on, we'll be talking about negative impacts as that strategy number 2. So next slide. I'm going to walk through the framework a little bit, and then we'll talk about each of the 3 strategies in a little bit more detail in terms of where they are and next steps for implementation. So really the purpose of pulling all of this together was to provide some structure and some documentation as we operationalize these strategies. This is something where your recommendation had really relied on other committees. So strategy 1 was referred to the Health Plan Quality Metrics Committee of the Oregon Health Policy Board. Strategy 2 was referred to the Health Equity Committee of the Health Policy Board. And there are a lot of moving parts that we want to keep coordinated between all of these different committees and conversations. So we're viewing this framework document as a living document that will update to reflect these conversations between the committee meetings, both your committee meetings and the Health Plan Quality Metrics, the Health Equity Committee, and the Oregon Health Policy Board meetings. There might be other groups that we need to pull in. There's also some agency work that we'll need to pull in, both internally to OHA and in coordination with DCBS for some of the commercial measurement. So this is definitely a living document, and this is very much a draft, and we will update as we go. So we'll add measure details, we'll add data sources. If new content areas are identified for any of these strategies, we will add that in as we go. And again, we want to clarify the interactions between all of the different committees. And this document, an early draft, we got some feedback about, oh, well, where are all the pieces of analysis about utilization and cost drivers, and shouldn't that be part of it too? And yes, that is part of this body of work, and we really see that as captured under the data use strategy, and there'll be some data use strategy documentation and those things move forward in parallel, but this is really specific to the quality and equity work stream. So in some ways, we're trying to silo things that really do have a lot of overlap, but we're trying to silo because the process and the folks involved in the development are a little bit different, and we're trying to keep those next steps clear. So this all is complementary and will move forward together, but the framework for monitoring is really focused on the quality and equity recommended strategies. Any questions about the high level framework or the examples from other states before we talk about the specifics? Like William?
Hi, yeah, I was trying to figure out here where to put my hand up and couldn't figure that one out. But I thought it was interesting around those percentages of the increases that were that I think Michael put up there or talked about. And I'd be very interested in that. I think it was 4.9% is what the allowable went up. Is that correct?
Yeah, and that's on average between 2015 and 2018.
Right, and then the out of pocket was up 8%. But do we know the fourth leg of that stool is how much did the assistance go up? So in other words, if allowable went up 4% and out of pocket went up 8%, truly what was the overall change, I guess, in the actual collections? So I'd be very interested in that. 4.9 is probably not what was actually collected because of assistance programs. But again, it gets to that benefit design and putting more and more pressure on the consumer versus, I guess, overall on the system to lower cost.
Right. Yeah, we don't know how much was actually collected, and as we've talked about before, William, as the consumer share gets larger and larger for commercial spending, there's more and more burden on providers to collect amounts and more and more difficulty for consumers to pay it.
Yeah, and I'm just thinking we should have a way, and I've talked about that before, but I think there are ways to track that so we can totally really understand, what's going on in the area of allowable versus really what was collected.
Mm-hmm.
Okay, if no other immediate questions, let's go to talking about some of the specific strategies and where we are. So this first strategy, reporting on quality measures, the committee's recommendation from January was that this should be a request to the Health Plan Quality Metrics Committee, which has an annual aligned measure menu set for CCOs, PEB, and OEB, and that would be the starting place because we already have measures selected in the state and we didn't want to start a new committee that would be responsible for selecting measures. So our current status is we introduced the context and this request to the Health Plan Quality Metrics Committee at their February meeting. They were open to it and they had a lot of questions, and we will be reviewing the process and the draft framework and actually beginning to start thinking about which measures from their menu are most appropriate for this purpose at their March meeting, which is tomorrow. So we are hoping that the Health Plan Quality Metrics Committee will be able to go through their aligned measure menu set and select a subset of measures that they recommend for this strategy, quality reporting in conjunction with the cost growth target, by June. We also have already identified a couple of areas that are maybe not fully represented in the Health Plan Quality Measures Committee aligned measure set. Sorry, I'm trying really hard not to talk in acronyms. Some of those areas might be additional patient experience and patient experience measures that are not currently reflected in the menu. There are a couple of other places where there might need to be some additional measure exploration. One example of that is measures that are appropriate for Medicare. So the Health Plan Quality Metrics Committee's scope is really focused on Medicaid and commercial through PEB and OEB, and they haven't necessarily thought about if all of their measures are appropriate for Medicare. So they'll be reviewing that and identifying gaps, and then we might need to do a little bit more digging of existing data sources, existing reports that would be appropriate to fill some of those gaps. So we'll be bringing back updates on that as we move forward with the Health Plan Quality Metrics Committee. And again, the next conversation with them is tomorrow. Felisa? Do you have your hand up?
I do. I have a question about this and then a comment. So I think my question about this has been this committee, frankly, has been notoriously not great on looking at measures and how they impact equity and how those measures get measured for communities of color in our state, and has repeatedly talked about communities of color in Oregon as statistically irrelevant. So I think it's very critical that when we're looking at this, the impact of these measures, that is taken into account, and which measures get chosen, that equity component is taken into account and not put in a separate bucket. So that's my comment. And then I think my question is I also feel like we have lessons learned from sort of the managed care portion in the late 90s, early 90s, late 90s, around what were the impacts on managed care around those quality components, and what did that really look like? And so maybe it would be good to just actually do like a little bit of a flashback and pick some of those metrics, but I'm not sure that that's actually doable, since we're going to kind of start from fresh about which metrics we're picking.
Thank you for that. I will definitely add that to my list to go back and dig into a little bit. I do want to address your comment first about equity. And again, this is one of those places where there is a lot of overlap between all three of the strategies in this work stream, all three of these conversations included in this framework. And we're siloing the conversations a little bit with and across the committees, but the intent is not that they don't get connected, and that we're not looking at, for example, stratifying all of these quality measures by populations. We're not, that is certainly part of the expectation. We are not planning on asking the Health Plan Quality Metrics Committee to pick, quote, an equity measure. We know that conversation has been really challenging for them in the past, and we didn't want that to be a derail of the conversation of focusing on the quality and access measures that we know are maybe a little bit more foundational. So we absolutely.
This is like, I feel like this is years of like pushing me to my brink on this issue, Sarah. So I know that you are stepping into that in a place that is not helpful. So I'm going to try to be as productive as I can in this conversation, given the long and tiring conversation I've had about this for years. I am not asking for an equity metric. I am asking that the metrics that are chosen can be broken down by population so we can watch and see what the impact is on communities of color in our state who have been historically marginalized, underrepresented, and frankly, over the last year, ignored and have died at higher rates. This committee has historically not been able to grasp that concept, has set that aside at various points. So if the unintended consequences that we are tracking only apply to the white, cis majority in our state, we are not looking at unintended consequences when it comes to quality. So I'm just going to leave it there. I don't feel like I need any sort of more explanation or thought on that. But what the expectation is that will be taken into account when these measures come back and are looked at.
Yes, absolutely. And not to get into the weeds on this, but I do want to provide one additional point of context that might be helpful. The Health Plan Quality Metrics Committee to date has been focused on selecting measures specifically for health plans. And there are some operational differences in how those measures are used than how measures will be used in the cost growth target program quality reporting, where we are looking at a state level as a starting point, and that changes some of the options for what we can measure, and that opens some additional conversations that maybe had been closed before. But I'm happy to take this offline, and I think Kevin has his hand up as well.
Can I just respond real quick to you, Kevin? I think I hear what you're saying, which is if they pick a bunch of measures that can't be broken down by race and ethnicity or by other populations that we're worried, that's not going to be acceptable, and we would agree with that.
If I could just jump in and comment as well. Felisa, first, thanks for saying that. I think you're spot on, obviously correct. I think one of the things that we need to figure out how to do is, aside from whatever the committee picks in terms of health plan incentive metrics, And nothing about that keeps us from doing exactly what you're saying, which is administratively breaking down the data by different populations to be able to display what's happening. Whether that's included as part of the metric is a separate discussion that also needs to happen, but I think we can provide more transparency on that basis and can look at doing that.
And this is Kevin here. Thank you, Felisa, for saying that. And I also agree, as a person that is on the Health Equity Committee of the Racial Justice Council, and I lead health equity efforts within Samaritan, I completely agree with your comments. And I also wonder if there's now an opportunity for the Health Plan Quality Metrics Committee to look at leveraging the need statewide amongst providers, hospitals, and plans, the capturing of real D data, because you can only produce your health equity outcomes if you know your population that you're working with in the first place. And right now, the availability or the ability to track real D in disparate systems of electronic medical records or whatever is definitely needing to improve. So I'm wondering if that could be a conversation as well with the Health Plan Quality Metrics Committee, because a lot of the health plan measures that have already been picked could produce health equity outcomes based on the breakdown of real D data. Also with sexual orientation, gender identity data as well. But it is a lift on the provider side and the hospital side to start to develop those. But the Quality Metrics Committee could be a communicator of the need for breaking down that data from a health equity outcome.
Thanks, Kevin. We will take that back to them as well.
Other comments about quality measures? And Sarah, I had my hand up too, just asking, do we have any participants that are from our partner organizations that attend the HPQMC? So what is our link of getting information in a bi-directional way to the HPQMC? And maybe we don't know that yet.
Yeah, I think there is potentially some change in who's engaging with HPQMC as this request becomes work that they're doing over the next 3 months.
Okay.
We might see additional public comment feeding into HPQMC. Certainly all of you as the implementation committee are welcome to listen in. We are doing a lot of staff work behind the scenes to keep the conversations coordinated and to update in that bi-directional way, but that's not exactly what you're saying with the stakeholder perspective. Yeah. Thank you. Pat, do you still have your hand up for a comment?
Nope, sorry, that was from before.
Thanks. Okay, let's talk about the second strategy for a few minutes then. So this is the negative impact of the cost growth target. And again, just wanting to recognize that overlap where there are absolutely the potential for negative impacts relating to quality and access that might be captured in the quality measures that we would be identifying in strategy 1 and some of that stratification and analysis that we can do. We are thinking about this as some of those other domains of potential impact. So for example, this might be where we look at consumer out-of-pocket spending. We've definitely talked about that as a committee before, wanting to look at things like spending as a percentage of income, or healthcare spending or out-of-pocket spending as a percentage of income relative to wage growth, relative to consumer price index, relative to a lot of other things, total household spending. We know that another area of interest where we might want to be monitoring for negative impact is on the healthcare workforce. So making sure that there aren't impacts in terms of salary, benefits, wages, hours worked, anything like that in cost containment efforts that might be implemented. This is a little bit developmental. There are definitely some other domains that we would expect to emerge as we have these conversations over the next couple of months. We will be having a conversation with the Health Equity Committee about this in the next month or two, and asking them to focus not on the pick measures for us in the same way that the HPQMC conversation will be going, but on the let's make sure that we're casting a really broad net and thinking about all of the places where there could be negative impacts on consumers, on patients, on the workforce, and other things that haven't been on our radar yet. And then we'll get more specific in terms of how we need to monitor that, whether that's new data collection efforts, whether that's coming back to specific measures, whether that's utilizing other data sources that are available that we can tap into that maybe we haven't used as much on the healthcare side. So for example, this workforce question, we've been doing some work with the Department of Employment to see if we can use their data that they have on wages and FTE worked and breaking that down by healthcare industry subcategories to use as a tracking. So that's not data that we've really pulled in before, but it's something that we're excited about being able to explore. And we think there are some other likely very similar conversations about data sources that could be explored and tapped into for this reporting. And again, our intent would be that any measures, data sources that we end up pulling in to this strategy would be reported out for specific populations wherever we can. Comments or questions about strategy 2?
Yeah, and Sarah, are you wanting to have conversation now about maybe other potential negative impacts that weren't initially included that we should start to put on this list? Or are we wanting to do that at a later date?
I do want to have that conversation today. So if you have immediate thoughts, please share them.
Yeah, one came to mind from my perspective, and you talked about availability and access. And one area that we may need to start to focus on and track, but because of the reduction of RVUs going to clinicians, whether they be specialists or physicians, and also service lines that hospitals are providing, and I'm thinking now of some of our smaller community-based hospitals, but as it may become more expensive to have clinics or hospitals provide certain services due to the healthcare cost growth target, is there a potential for some of those services being eliminated completely from the community? And I think that's a really important negative impact to start to track, and much more proactively track instead of retroactively.
That's a great addition. Thank you. Jessica.
Also along those lines, you know, when I look at potential negative impacts, you know, like Kevin mentioned, if there are certain things that become very expensive for small hospitals or providers, you know, are we encouraging more mergers and acquisitions and sort of bigger you know, hospital sort of systems, which sort of limit competition, right? And could get us into a point where we're just, you know, we're riding that right below the cost growth target every single time, and we're not, you know, we really are not getting what we'd hope for, which is sort of a downward trajectory on the cost.
Definitely, thank you. It's not in the framework yet, but I can tell you that internally we've been having some conversations about different ways to look at impacts on cost and cost drivers pre-post mergers. We've also been thinking about whether or not we should utilize our all-payer claims data to do some analyses of the level of consolidation. And so I think those are some things we'll be getting into over the next year. And John McConnell, heads up, we hope to consult with you on that.
So this is Kevin again. Oh, I'm sorry, I'm not watching hands. Did somebody else have a hand up?
Go ahead, Kevin.
Great. I was quickly going to say too, from the health equity perspective and mirroring what Felisa was saying earlier, but if we're seeing that BIPOC communities are being impacted more negatively due to changes coming around from the healthcare cost growth target, what is the mechanism to get that communication up to our level so that we are aware of it and can start to create those interventions? So it's more that process of communication flow.
And I think this goes back to that simplified cycle slide that we were looking at a little bit ago, where there will be the data, the measurement, the reporting back, where that comes back to you and that becomes part of the discussion about what do we do about this? What are the strategies for taking action? So I would view all of this work in this framework for monitoring as similar to the work in the data use strategy, where we will bring this back to the committee for reporting out and discussion.
Great. Go ahead, Ken.
Sarah, since there's obviously, this isn't the only thing that would be going on in the environment, I'm wondering what the thinking is around how we get to causation. Kind of how do we sort through and attribute this happened because of this, or I mean, it's important independently, but that causation thing to me does have some relevance.
Yeah, I think that's off the top of my head, I think that's a conversation we hope to have with all of you. I think as we're thinking about this analysis, we're viewing this as a dashboard. These are warning signs. We're not trying to prove causality with any of these given measures or any of these given buckets. I think this is more, here are things that it's important to keep an eye on. And then if we see anything that looks alarming, we should discuss more. It may or may not be causal, but we would need a lot more context. We're not gonna be able to prove that with, a single algorithm. Michael, have any of the causal conversations come up with Connecticut?
No, not yet.
Other potential negative impact areas we need to be aware of? Okay. Sarah, did you want to move us on to the next area?
Yeah, on the next slide, this is still with strategy 2. This was just an example, again, as I mentioned, of the workforce and the Oregon Employment Department data. So again, we're starting to identify potential measures, and I'm saying measures for all of this, but not necessarily the same thing as a health plan quality measure. This might just be a data point or an indicator. So this might be distribution and demographics of providers across the state and how that's changing over time. Again, this might be the wages or FTE for healthcare occupations. And we're also talking about other, there might be some other indicators that we could pull in. We also think there's an opportunity for this domain in particular to do some coordination with other groups. We have the Healthcare Workforce Reporting Program. There's also the Healthcare Workforce Committee of the Oregon Health Policy Board. So a lot of potential places to connect, and this is just one component of that broader bucket. Okay, so strategy 3. Next slide. So this is the analyses to identify variation and then taking action to address specific barriers to improve equity. So if you remember back to your conversations in the fall, you all recommended strategy 2 and strategy 3 as separate because it wasn't enough to just look at the negative impacts. It wasn't enough to just look at preventing disparities, but also to take deliberate action to improve equity and having that positive, proactive lens on things as well. So I think for me, I'm viewing this as a phase, as a slightly later phase to the work, not because it's less important, but because this work is really reliant on the data use strategy and all of the analyses that will be happening in the framework for monitoring under strategy 1 and 2 for us to come forward and say, here's what we're seeing around utilization, here's what we're seeing around access, here's what we're seeing around these negative impacts, and then think about what are the specific barriers and the specific actions that can be taken. So again, thinking back to that annual cycle of reviewing the data, thinking about what opportunities there might be, and then taking action. So we're not developing this in the same way that we're not looking for a set of measures where we say these are the 3 specific things that we're going to look at or the 30 specific things. But rather that this strategy would be informed by all of the other work from both the data use strategy and the previous 2 strategies. And we'll be able to then see the variation and decide where we want to focus attention. So we'll be having some discussion about this with the Health Equity Committee, but this is also, this will also continue to evolve as we develop the data use strategy and the rest of the framework for monitoring. Kevin?
Sarah, yeah. I know this is a later strategy, but I'm just posing the question to us. If we hear of a unique program that a hospital or clinic or system has already done in an effort to reach out and improve outcomes in our BIPOC community, what forum would we have the opportunity to share some of those best practices to help facilitate the adoption of equity outcomes and programs?
I think I would maybe defer that to the broader committee. Is that a conversation that you would want to have as part of opportunities for taking action? At some point, would we want this to be a subgroup that focuses on specific best practice sharing? I want to be careful of keeping the right level of balance because this could easily become, okay, this is now a learning collaborative to share best practices, and that might not be the right level of detail for this group, but I think I would defer to you on where you want to engage.
Thank you. Yeah, I like the thought of developing a work group. And right now I'm putting my CCO hat on with this comment, but in the early years of the CCO metrics, The learning collaboratives that were put on by OHA were very beneficial to the CCO, so we could all learn from each other. What are you doing with this specific metric? What program have you already performed that gave some positive results? How could we share and spread those promising best practices? So yes, maybe something like a work group that could take on that learning collaborative type of forum related to health equity outcomes.
Elisa?
Yeah, I think so. I feel like in some of the earlier strategies, so if this is a later strategy, if you go back to strategy 2 on the out-of-pocket costs, so there are components of these other earlier strategies related to equity that we already know around what is the disparate impacts that are currently happening. And so I feel like it would be good to incorporate those early on. We already know that people of color have higher out-of-pocket costs and are more likely to be underinsured than majority populations. We know that. That's just a fact. So as we look at the impact on out-of-pocket costs, I guess my question is like, how do you walk the balance if something is working or if something has a negative impact? And I think that this gets to Ken's point on causality, but also how, like, I think this is like the negative impacts piece. So if we lower out-of-pocket costs for people of color at a faster rate than we lower out-of-pocket costs, maybe across the board for the majority, that is not a negative impact. That's actually a net positive impact of the program that we potentially could see happen here. But where does that come back if we're only looking at sort of the negative impacts? And I also think like on this like follow-up on these follow-up strategies. And I really am, I guess I would feel strongly about like, I like the strategy 3. Each strategy to me does not need its own committee. And I actually think the 3rd strategy needs to be completely woven into the other 2 strategies and not a separate bucket where you can set it aside and develop it later. So, and I hear you trying to do that. I think that there needs to be a greater leap there is what I would say. So
thank you for that. And I want to clarify that it's less that we're setting it aside to develop it later, but more that as the conversations emerge, exactly what you're saying, if we're seeing trends in out-of-pocket costs change for one population faster than the other, that is a discussion, and that is part of the committee's cycle and process in all of this monitoring. It's not that we suddenly get to a tipping point and say, all right, it's now time to develop strategy 3. It's that strategy 3 will be sort of emerging and evolving. And I didn't put this on the slides, and I probably should have, but the committee did clearly recommend back in the fall as part of this this work stream that we should be looking at the positive effects as well as any negative impacts, and that would be part of this work. This would not be just looking for negative.
So outside of what's already been discussed, looking at what's been proposed so far, is there major content areas that any of you feel may be missing from the strategies that Sarah just outlined? And Felice, I do see your hand up still, so do you have another comment? I wanted to make sure that
I don't. Thanks, Kevin.
Thank you. So any major content areas missing? And any thoughts about the interactions in the proposed process between the committees that have been outlined? Do we feel we're on the right track? I'm not hearing a lot of no's, but it'd be good to hear some yeses or thumbs up. Catherine?
Hi, Kevin, I guess I'm pretty chatty today. Nobody could argue with any one of these. But what I struggle with still is to see the through line to what any and each of those measures are going to tie back to our overarching charge of lowering the total cost of care. So from a quality perspective, would love to see any initiatives that the data use strategies suggest that we also include equity and quality there versus relying on a generic chosen set of measures that may or may not be directly tied to any specific initiative. That creates work, so I think we should choose our metrics carefully, and we tie them back to our charge, because otherwise we'll create some bureaucracy that ultimately only leads to additional cost.
Good comment, Catherine. Appreciate it. Any other comments, questions, clarifications? So once this work starts coming up and the data use strategy is set, health plan quality committee, metrics committee has been meeting, what level of detail do all of you feel will be important to keep bringing back to this implementation committee for future meetings? Do you want high-level reports? Do you want to go into the weeds like some other subcommittees or committees might be doing? What level of detail? Is it the top 3 wins we're seeing, the top 3 barriers, now that we've started to look at some of those unintended consequences? Felisa?
Honestly, I feel like it's very hard for me to answer at this stage until you get the first set of information back. And then I feel like that's a point where I could say this is too much detail or too little detail, but it's sort of hard to sort of guess right now.
And Kevin, can I clarify the question a little bit? I think we're probably a ways out before we have some of the data on this, because we need to go through the process of figuring out what is going into that dashboard to begin with. So I think what we're asking is how much of the detail of the development process would the committee want? Do you want sort of a status update each meeting, and we can report back on which committees we've talked to and how the framework is evolving? Do you want to just be looped into an updated document every month or so? How much more space should we carve out in future agendas for discussion of how this is developing before we have the results from the data?
Thank you. Now that you framed it that way, yes, sounds much better and easier to address. But from my perspective, and please everybody weigh in, but a status report updates so that we can see, okay, what work has been done already, what's moving forward, but also be able to look at where are some of the where are some of the holes in what we want to have done, and how do we try to allocate more resources to try to backfill those holes. Other thoughts from the group? Brian?
More of a question. What's the forum around suggesting measures? So when I reviewed the document, there was a couple of measures that stood out to me that are pretty common and I think would be applicable and helpful around the equity issue that we're discussing. So what's the forum to share observations about? Have you guys thought about this? And probably yes. And then how come it's not on there from discussion?
If you have feedback about the document, specific measures, specific domains that aren't reflected, please just email me directly. I'm happy to take that feedback at any point.
Because this goes to the quality. Who's generating these quality measures? Who's the keeper of them?
So the process is we're hoping to work with the Health Plan Quality Metrics Committee to identify which measures we should report on. We did have a clarifying question that came up at our technical advisory group, I think last month, about who actually had to report these measures. Every measure we pick then becomes additional reporting burden for someone. And we wanted to be clear that the intent is that OHA would be reporting on these measures using the all payer claims database and reporting it out statewide. So this is not something that then suddenly becomes every payer or provider has to report on the measures that are included.
And also, Sarah, it's correct that the Health Plans Quality Metrics Committee meetings are public meetings.
Absolutely.
So that, you could have representatives from your organization sit in, you yourself could sit in and give them guidance during public testimony.
And I would also this, I'm not sure how appropriate this is, but I think this is an iterative process between two committees. I don't know that we've said that any one committee has the final say. So I don't think that you then have to sort of live with whatever the Health Plan Quality Metrics Committee recommends back if you don't agree, or if there are, as you say, gaps that need to be filled or fleshed out. I think we'll see how far one committee gets, bring it back, and vice versa. I don't think that we've set up a very formal governance structure where there's a sort of a final decision made by anyone that you're not part of.
That's good to hear, Sarah. So it'll be more like a symbiotic relationship.
Yes.
Good. All right.
I think it would be helpful to take a look at how this is evolving during our meetings rather than just get a report every once in a while, just so that we're all familiar with how things are going, so that when we do start to collect data and review that we really understand how this kind of came to be. So I think that would be really helpful.
And also, Michael and Megan, I'd like to make sure that this committee is aware of what some of the wins, but also challenges that the other states that are going through this modeling are encountering, just so we could learn from them.
Sure, we'll be happy to share that with Kevin.
Any other topics, questions? Brian, did you have your hand up or?
I don't.
Okay.
They said I don't need to have it up.
All right. Any other items, Sarah or Jeremy, that you wanted us to have during this discussion period before we start looking at moving into public comment?
That's everything I was going to share. Again, I just reiterate, if anyone has feedback on this, whether that's high level or very granular ideas or measures to look at, please let us know. Your feedback would be great. Jeremy?
Nothing for me. Thanks for the good discussion.
Great. Okay. So we're now going to move into our time period for public comment. And do we have anybody that has signed up for public comment? Just to alert the implementation committee that in the packet, there was a written testimony of public comment that was sent to us for your perusal. And that public comment document came from Don Mazziotti. So any others that have signed up for public comment at this time?
Nobody has signed up.
Okay. Any attendees that are not part of the implementation committee that would like to do public comment? I'm just giving a longer pause in case some people are having trouble getting themselves off mute, etc. Okay, so hearing none. A lot of discussion about the various strategies that were going to be in place, the discussion of the need to link up and have a symbiotic relationship with the Health Plan Quality Metrics Committee. Definitely, health equity needs to be an underscoring principle of all of the work that we do as a committee and as subcommittees that move forward. We also heard from Michael about the other states that are part of the project moving forward. And Michael, can you remind me of the name again of this grant that you had referred to of the 5 states?
Oh, I don't remember exactly the specific words.
Okay.
Sarah, Jeremy, do you have it at hand?
It's the Peterson Milbank
Program for Sustainable Healthcare Costs.
Program for Sustainable Healthcare Costs.
Okay. The reason why I wanted to bring that up, it might be some good homework for the group while we have a break until our next May meeting to go back and do a Google search of the Peterson Milbank Award for Sustainable Growth and do some reading of it, make yourself familiar with what is out there. And we'll also make sure that we get updates at our upcoming meetings from the wins and also some of the opportunities ahead of us for our own work in our state. So
we'd be happy to send out links to the other states and to the Peterson Milbank documentation to put it so people don't have to Google for it.
That would be awesome, Sarah. Thank you for taking care of that. That's exciting. So our next meeting will be May 24th at 8 a.m. That time seemed to work for most individuals. Is there any parting comments or statements that anybody wanted to make before we look at wrapping up almost 34 minutes earlier? Ending a long 3-hour meeting is always good when we do it ahead of time. All right, I'm not seeing any hands raised. So we will bid each other adieu and connect again in May for our next implementation committee meeting. Everybody stay safe out there. If you haven't gotten your vaccine, please do so. And we will connect with you in a couple of months. Thanks so much.
Thank you.
Thanks, Kevin.
Thanks all.
Right.